Okay.
And one of my uncles, he died of a blood clot. So it was one of my mom's brothers.
Oh, wow.
And I found out about it going over to Hawaii. When I came back from Hawaii, I went over to Hawaii for a California, Hawaii, Nevada athletic training conference. So basically what I do is I do the same thing Dave Beamer does.
So Dave, before you go too far, as we're getting people in, I think I probably should.
I think you should.
Yeah, introduce you. So let me find, I want to share my screen too. So welcome everybody.
Hi, Adriana. Hi, Alice.
Elise, that's Elise.
Hello. Hi.
Nice to meet you.
Hi. I'll just tell you guys, this is my brother-in-law, Dave. And Dave is also sports medicine, right, Dave?
Correct.
Okay. So, do you want to start from the beginning?
Yeah, I mean, I can tell you kind of what's going on just so you people know. So, as I was telling people earlier, for me, my blood clot is a genetic factor. It's the Leiden factor. And if you have one of the recessive genes, you have a 15% chance of getting a blood clot. If you have both of the genes, you have an 80% chance of getting a blood clot. And I have one, and I got my first blood clot about 20 something years ago, like 22 years ago. And I got it back from flying back from Hawaii, where I was at an athletic trainers conference. And at first I didn't know what was going on. All I knew was that my groin and my quad was just extremely painful. And then I waited probably about a week or so, just because I thought it was, because I wasn't drinking. I normally drink a lot of water, and this particular time I wasn't. And I just thought it was kind of more of a, just a muscle strain. And then my team doctor at GAV, a guy by the name of Dr. James Colville, he's an orthopedic surgeon. He said, dude, you got a blood clot. You need to get that checked. So when I got my first clot, I was on Lovenox shots, which I tell you hurt like hell. To give yourself these shots, they're extremely painful. I had to do it twice a day. And I had just started as the athletic trainer at Hollister High School. So 7 o'clock in the morning, 7 o'clock at night is great, unless you're covering a football game. Then you have to kind of go hide in the bathroom stalls and give yourself shots, and you got to hide your needle so people don't think you're a drug addict or something. And I was also on warfarin at the time. And when I first started, I had to get a blood test twice a week. So a DVT is a deep vein thrombosis. Basically what that is, it's where the easiest way to think about it is the drain in your sink. It's all clogged up with all the junk you put down your sink, and it doesn't allow the blood to go through. And if the clot breaks free, if it gets into your lungs, it can be fatal. If it breaks free and gets into your brain, it could really be fatal. It could cause strokes. There's a lot of different things that they can do. So anyway, my doctor wanted to make sure that my clotting mechanisms were where they were supposed to be. So I was getting my blood draw twice a week for about 2 months. And I had to stop eating all kinds of stuff. I had to stop eating potatoes and green leafy vegetables, pickles, I mean, my diet was basically peanut butter. You couldn't eat peanuts or peanut butter, just to get my numbers in line. And then I went from having my blood drawn twice a week to once a week to once every 2 weeks to once a month. And then finally we took me off warfarin. I was wearing the compression stockings. And girls, I'll tell you, I feel for you when you wear nylons. But these are thicker. These are thicker though. These are like 4 or 5 times thicker than what you would normally wear. And they are a pain in the butt to take off. Putting them on is one thing. Taking them off is something totally different. And I was actually doing really good. I was on an aspirin, 2-a-day baby aspirin a day regimen, after I had my first blood clot at the age of 35. And then I was, things are going really, really well, probably for about a good 15 years. And I'd say probably about 6 or 7 years ago, I got another clot. I might have had others in between, but I definitely got one after that. This one settled in just above my calf muscle. And now I am on Xarelto every day for the rest of my life. One of the worst things is now that I'm on Xarelto, first of all, I can't give blood anymore, which to me is it's a biggie. I used to love giving blood. I used to love doing, platelets. I did all that, but I can't do that anymore. If I have to have any major surgeries, I have to let people know, and I might even have to do what they call bridging, where I would have to go back on the Lovenox for 3 or 4 days before the surgery and everything else. Compressive socks help really well. Compressive socks are basically, I think the highest is a 30 millimeter compression. And what it does is it compresses the leg. And as it compresses, it also moves around. So it actually kind of massages it. So it has all the blood can flow back up the leg in the lymphatic system. I don't wear it now just because they're so uncomfortable. And probably the biggest thing right now that really totally sucks is I can't wear 501s. I cannot wear jeans. If I put 501s on, even if I have a compression stocking on, I'll never be able to get it off because my leg just swells up way too much and it gets really, really bad.
It's like double the size of your other leg, right? Kind of.
At times, yeah. Yeah, at times, and some people think I actually have a prosthetic leg.
So Dave, what happened? Like last year, you had gotten a wound in the shower, or
right? Yeah, it was really weird. Last year, I was climbing in the shower, and my foot, it just caught the edge of the shower as I was getting in, and I got this basically a cut on my leg. And we got it to stop, and it was doing well for a while, and then all of a sudden it just became this open wound that would not heal. And I tried everything to get it to heal. And if I had a bandage on, a Band-Aid, it would actually make it worse. The wound just kept getting worse and worse and worse, and it just was not healing. So I went back to my doctor, and he suggested that I actually get admitted to the ER. The ER ran a bunch of tests, and basically I had some kind of so with normal people, if you have a skin infection, okay, yeah, big deal, take some antibiotics and you're fine. I was on an oral and an injectable antibiotic routine, and my leg was probably from about mid calf all the way down to my ankle. It was kind of a purplish, pinkish color. So like when your fingers get cold, how it turns kind of a purplish color, not blue but purplish, and it was like that, and it was really swollen and really tender. I went into the dermatologist. The wound finally healed after some really high doses of antibiotics. and I ended up going into the dermatologist because I started getting a really bad rash after the wound had healed. And I had asked the dermatologist about it, and he said, "Yeah, you had just a regular skin infection." He didn't really tell me what it was. He said, "But you have a skin infection, and it's now you're probably going to have this kind of a rash before." He said you might have it again, so he gave me some steroidal cream to help with the rash, and the rash has gone away. I have no problems with the rash. I have no problems with this wound, and it was the weirdest thing. It just would not heal, and I actually thought I was going to have to go in for like surgery, or like some kind of plastic surgery, or some kind of a mesh over the wound. It was just like a regular, it wasn't really a cut. That's how it started out, but it actually became kind of like a bed sore
An
almost.
ulcer. Yeah.
Yeah,
Pressure.
it was really ulcerated. It was an angry wound, and there was nothing I could do for it. It didn't really hurt that much, but man, it just would not heal. And when I asked my doctor about that, and the reason I have the doctor that I have now is when he was in college, when he was in med school, he actually specialized in blood clotting disorders. And he told me that because I'm on an anticoagulant, because I'm on Xarelto, which of all the drugs I've taken, Xarelto is my favorite one. Partly because they don't taste nasty, they're small, and I don't have to have blood draws. I don't mind blood draws, but it just really, it kind of screws up your
day.
your week and your day, because you got to plan around blood draws. But he said because I'm on Xarelto, which is an anticoagulant, that sometimes my immune system might be a little, it might be a little impaired, and that's just another thing that I have to be concerned about as I go on.
Okay. So thanks, Dave. Does anyone have questions?
Please ask me questions. Don't be silent. Because you're not going to learn if you don't ask a question. The only stupid question you don't ask.
Are you a diabetic?
No, I am not. Never have been. I do not have high blood pressure. My blood pressure is still in the 120, 125 over 80, 85 range.
Okay.
I'm a lot heavier now than I used to be, especially with this coronavirus. Haven't really been able to exercise like I wanted to, but exercise, it was not an exercise problem either. I can tell you this though, it was on my right leg, and I'll tell you, man, if I get kicked in the shin, I'm ready to cry. It is extremely painful. If I bump my leg on my dog whips her tail into my leg, or somebody kicks me in the shin, or I hit a table, it's extremely painful. Keep going. I'm ready. Fire away, ladies. Guys, whoever's there.
How comfortable are you in when you're lifting anything? Is that painful, lifting?
No. In fact, weightlifting is probably one of my favorite forms of exercise. Riding a bike doesn't hurt. Walking doesn't hurt. Exercise doesn't really hurt. In fact, exercise helps a lot, because it helps to get the blood moving at a faster pace through my body. So it doesn't really have the chance to pool. But it's just with the coronavirus lately. I don't know about you, but man, I've just been so tired. It's like I'm so taxed from having to avoid everything that the energy to walk the dog sometimes is kind of tough. So I can't.
We've kind of had other things too, Dave. So.
Well, yeah, when the dog dies, that it's kind of bad, and because we had that happen, and it's been a really tough year. I can't wait for 2020 to be over. I mean, I thought 2020 was supposed to be perfect vision. I'm not seeing it. Anybody else? Go ahead, ask, please. I know you're out there.
So
what kind of referral? Sorry.
Go ahead. No, go ahead,
What
Lynn.
kind of referrals did you receive from the doctors?
So the first doctor I went to, he actually sent me in for a blood draw to see exactly what was going on. And we had to get all my coagulant numbers in line. One of the referrals I got was actually to a cardiovascular specialist, because at one time they were thinking about, from where the clot was located, they were actually thinking about putting it's called an umbrella. Basically, it's a filter. It's an upside down filter. So it looks kind of like an umbrella. And they were going to put that in my femoral artery, femoral vein, just in case the clot broke off. So that way we wouldn't have to worry about it going into my lungs or my brain. But when I went in and met the vascular surgeon, he recommended against that. Number one, because I had had the clot long enough that it wasn't going to break off. Number two, he didn't want to do it because he didn't want to cause more clots because of my condition.
So basically, it's encapsulated itself now, right?
Correct.
Correct. It's not going to go.
It's not going anywhere. Yeah, it's not going anywhere. It's made, and that's one of the things where if you look at so we're talking about a deep vein thrombosis. So the deep veins in my quad muscle, one of them is it's compromised, and it instead of being this big around, I don't know if you guys can see that, instead of being this big around, we'll say it's kind of like that big around. So what happens, your body's amazing. It does amazing things. And with me, when that one vein kind of got compromised, some of the other veins took over and started doing the work of this guy. And that's why the superficial veins on my quad, you can actually see them more pronounced on my right leg than my left leg, because now they're having to work harder. They're doing their work plus somebody else's work.
I'm sorry, maybe you mentioned it, but what was the cause of it? What was the trigger?
Genetics.
Wow.
So my mom's father died of blood clots. He was a smoker, but he died of blood clots. And one of her brothers died of blood clots. Basically, the way I got it, and I didn't know that I had the Leiden factor, I was coming back from a trip to Hawaii. I went over to Hawaii for a professional conference, and it was the trip back. I didn't get up. I didn't walk around. I actually thought it was more, because I normally drink anywhere between 100 and 140 ounces of water a day. And it just so happened that when I got the clot, it was a really, really hot time of the year. I don't drink soda. You could probably count on one hand how many sodas I've had this year, and you could probably cut off a couple of fingers. I just don't drink soda. I'm also ADHD, and soda does not work well with me, and I know that, so I don't drink it. But I didn't have any. I hadn't had any water, and I thought it was a really bad muscle cramp. And I waited probably a week after I had it, and I was still having the pain. And I saw my team doctor at Gav. I was the trainer up at Gav at the time. My team doctor was the U.S. Olympic water polo doctor. And he told me I had a blood clot and I needed to make an appointment with my personal physician. And I did that. And then we started doing the blood tests and everything else. So it was a genetic thing. So one of the things I'm going to tell you, if you're ever flying long distance, by long distance, cross country, I would say anything more than 2 or 3 hours, you need to get up and walk around. I didn't get up and walk around on the plane. You need to get up and walk around. You need to take your shoes off. You need to stretch your legs. Same thing when you're driving. Pull over, walk around. What I do, especially if I'm going on a long trip and I'm on the freeway, and I put I'll put the what am I thinking here, Deb? Cruise control on.
Yeah.
And I'll actually move my leg. I'll wiggle my toes. I'll bend my leg. I'll flex and extend my leg. I'll, try to rotate my leg. I'll move my foot into dorsiflexion, plantar flexion as much as I can, just so I'm moving it. Normally, in a normal day without the coronavirus, when I'm teaching, I walk around the classroom all the time. Number one, my ADHD, but number two, also my legs. So that way it kind of helps get the blood circulating. So I don't know if I gave you more information than you wanted, but there you go.
You also have one of those compression the sequential
Yeah,
compression stockings,
Yeah,
right?
so as an athletic trainer, I have this thing called a sequential pump. This thing is way cool. I love this thing. It's called a Normatec. Basically what it is I have it's for an arm. I have arms, I have hips, I have legs, and it's a little box, probably about this big. And it's battery operated. And what it does, the pump will start to squeeze my toes, my ankle, my shin, my knee, my thigh. And then it kind of goes backwards. The sequential pump is used, it's called Game Ready. It's something that a lot of athletic trainers use on their sidelines when someone first gets injured. What we want to do is we want to limit the amount of swelling in the injury site. So we put ice on there, we pack it in ice, and we put on the sequential pump. So we pump all the fluid out of there, because the sooner I can get rid of the swelling, the sooner I can get you back to playing safely. And I've been using the sequential pump probably, God, for about 2 months now. And oh man, at the end of the day, your leg just feels heavy because it's swollen. Sometimes, you just feel like taking a pin and popping it just to relieve all the pressure. Oh my God, that feels good. But so I put the sequential pump on, and oh man, it's night and day. It feels really, really good.
Anyone else?
Anything else? If I was you people, I would take advantage of this, because you don't always get guest speakers that are this willing to talk to you.
I have one question.
Yeah, go.
What are the goals that they made you do or you have accomplished after the
You
club?
mean so what I'm hearing you say, I want to make sure that you and I are on the same page. You're saying, what were the goals of rehab for me? Is that what you're saying?
Yes.
Really, there wasn't really any goals of rehab, except try to limit my long plane trips without getting up and walking around. Same thing with I'm supposed to be wearing my nylon every day, my compression sock, but man, that thing is so uncomfortable that I just can't wear it. I just can't. I try. If I have somewhere where I have to wear long pants, I actually own long pants, but I wear shorts all the time. I wear shorts in the snow because it's easier. But I have long pants, and if I'm wearing my long pants, I make sure I wear my sleeve. So there isn't really a whole lot of goals of rehab for this. You just want to try to limit how you can get other ones.
Yeah, so I think Lynn is talking about, so in nursing, we talk about, so basically you had the problem with the clot, so it was a problem with perfusion and a problem when you have the wound with tissue integrity.
Right.
So we talk about those are the problems. So how do you come up with the goals? And
right. So my first goal was to get all of my clotting numbers to an acceptable level. So I mean, like, I don't know if you caught me, Lynn, when I first was talking about it. When I first got my clot, I was having blood draws twice a week, every Tuesday or Wednesday, and every Saturday morning. Saturday morning at 7:30 in the morning. I don't know about you, but 7:30 in the morning on Saturday, I'd rather be doing something than getting a blood draw. So when I first got my clot and I was on Lovenox and warfarin, our goal was to get my numbers at a place where we could work with them for the medications. So I mean, my warfarin dosages went from 10 milligrams down to 5, up to 7.5, back up to 10. I mean, I was all over the board. So I had to quit eating potatoes, meaning potatoes, potato chips, French fries, hash browns, mashed potatoes, baked potatoes. I had to quit eating peanuts, peanut butter, anything with peanuts in it. I had to cut out green leafy vegetables, spinach, chard, kale, lettuce. I had to cut all that out. My diet was very, very boring. In fact, I would say my diet was more boring than somebody that is suffering from ulcers. It sucked. And it was right around Thanksgiving, which made it even worse. You have all that great stuff at Thanksgiving. You've got celery and celery in your stuffing and everything. I had to cut all that out until we got my numbers at a reasonable rate. And it took me a good 2 or 3 months to get to where the dosages of warfarin I was taking to where I was only taking 5 milligrams. I think it was 5 milligrams twice a day. So that was one of the things that we had to do. After that, then it was more of a monitoring to make sure that I didn't have any more blood clots thing I had to look, things I had to watch out for. One of the things that also happens when you're on blood thinners is I couldn't drink. I mean, I could drink if I wanted to. However, if I was going to be drinking heavily, it was recommended that I wear like a bicycle helmet, because if I fell and hit my head, then all of that swelling would go into the brain and you can die from that. So when I first did it, that was another thing. I cut out I cut out all my alcohol consumption. I quit taking aspirin. So a lot of it was just trying to get my numbers at a rate or at a place to where we could do something with them. I hope that answered your question.
When you were recovering from this event, were you in a hospital or in a long-term facility?
I did go to the hospital once for about 3 days when I got my second clot. And the reason that I was in the hospital is they wanted to make sure that my clot didn't move, and they wanted me to stay as still as possible, which, somebody with ADHD, that's not the easiest thing in the world to do. So I was stuck in a hospital for about 3 or 4 days. The first time, no, I was not in a long-term facility. I wasn't in the hospital because I had it for probably, probably 3 or 4 weeks before my doctor and I really got to a place to where we needed to go to treat this.
And how was the care? I'm pretty sure from one of those events, nurses were involved. Do you feel that any of them made an impact?
Well, the first thing, I thought I took really good care of myself. The second thing, when I was hospitalized, yeah, I had a lot of nurses in my care. Did they help me? Yeah, they did. But it's not easy when you're used to being active and doing stuff, and all of a sudden you got to sit there and do nothing for 24 hours a day for 3 days. It kind of sucks to not do that. So yeah, the nurses were a really big part, making sure I took my meds all the time. With my wound care, Mrs. Thorpe was really good about her. So her and I, we see each other, I'm probably not lying, 2 or 3 times a week. And if we don't see each other 2 or 3 times a week, we probably talk that much. She was really concerned, and she gave me a lot of suggestions about the wound that I got last year, just a weird infection that it just wouldn't go away. And we talked about it quite a bit. So as far as nursing goes, I just saw one of the questions on the chat. I didn't really read it. But I think that's a really good question. How would you counsel somebody on this? So I'll flip it around. So whoever asked me that question, I'll flip it around to you. How would you counsel somebody on this condition? What would you do?
And what is the connection between the green leafy vegetables and warfarin? Does anyone know?
Okay.
It's the vitamin K. It decreases warfarin effects, and it increases the chance of bleeding if there's a high hyperkalemia, right?
Yeah, keep going. How about the potatoes and peanuts? How about potatoes and peanuts?
What would you tell the patient if he loved peanuts and
And
potatoes?
peanut butter and mashed potatoes and baked potatoes. See, for me, it was a choice to get rid of all that stuff because I was just so mad that my numbers were all over the place that I basically just told myself, I'm going to do this. I'm going to get it taken care of as soon as possible. And it was boring. I'll tell you, that diet was boring. I mean, oatmeal every day with, boring stuff in it. I don't know how many of you people eat, oatmeal with peanut butter, which is actually pretty damn good, especially with your proteins and your fats and everything else from peanut butter. But I was going back to boring oatmeal.
So any other questions for Dave?
So, Deborah, if I can ask you a question, what was the question you put in chat? Because I don't think I can get on the chat. You had a question that you wrote in chat?
Yeah, I was just bringing up, you mentioned multiple times that, you were unable to eat kale and lettuce and celery. So my question to the group was, what's the connection between?
Okay. And one of the things, and this was all back when I was single. So when I was single, I would get a head of lettuce and I would get, a big bag of spinach. And then I would get a bunch of Granny Smith apples, and I would either get a lime or a lemon. And I would dice up the apple and put lime or lemon over the top. So this way it wouldn't turn brown. And I would make my salad for the week. I'd have a big bowl of salad that I would have with every dinner. And it really sucked because I couldn't do that anymore.
Yeah, that sounds like it.
And I hated it. And because, I mean, when I first got my first blood clot, I was probably down to about 220 pounds. I'm not 220 anymore. I'm probably closer to 240, 250. But that was also 22 years ago. But yeah, and it was total life changing. It totally sucked. I hated it. But I couldn't eat salad.
Yeah.
I love rabbit food.
Well, thanks, Dave. That I think just watching you over the years and having to deal with this when we were talking the tissue integrity, and I was thinking about the wound and all of that stuff. So thank you for sharing.
Oh, yeah. My pleasure. And, if you have any questions, please forward them to Mrs. Thorpe. I'd be more than happy to answer them. If there's anything I can do. If you need me to come back for something else, I'd be more than happy to do that. Whatever you guys need. We need more people out there like you.
Thanks, Dave.
Sure.
Okay.
My pleasure. Thank you.
Thank you.
Thank you.
You're welcome. Bye. Have a good night. Bye, Deb. Talk to you later.
Okay. Okay. So, so how is everybody tonight? Was that helpful? It just kind of put a face to some of this stuff we've been talking about, right? It didn't exactly fall only into tissue integrity. What else did it fall into, the concept? What other concept was he talking about? Well, there's a couple.
Inflammation.
Inflammation, okay, good. What else?
Even part of it, infection, because he needed to be careful to prevent it.
Good. There's a couple more.
Nutrition.
Nutrition, okay. And why were you thinking nutrition?
Because of his diet, all the changes he had to make with his diet, and also like the stress and coping with all that too. That was something really
Yeah,
big.
good. There's a couple of big ones that they're probably so big that you haven't, it's just kind of like, oh yeah, that's for sure. I was thinking that. So we know tissue integrity. What else? What is happening? Why this all started?
The circulation, blood circulation.
So perfusion, right? Perfusion. And I know we covered a little bit, but it's not included as a concept anymore, clotting, but clotting now falls under perfusion. What else? I think you've kind of covered them mostly. We said nutrition, perfusion, stress, coping, mobility, because he could have been, if he wasn't someone as active, because he shared with you he has ADHD, and believe me, he does, he would probably wouldn't have been moving a lot either, and would that make it worse?
Yes.
Yeah. Good. Okay, so any other questions before we move along? I was going to go ahead and go into the PowerPoint. Is that what you guys want me to do, or are you thinking you want something else?
The PowerPoint's fine.
Okay, all right. Okay, so go ahead, what?
I thought we were going to go over a case study.
No, this is,
Okay.
yeah.
Okay. Thank
Yeah,
you.
the only other thing, this per se is a live case study, right?
Yes.
Okay. The other thing that we were going to touch bases on at the end, or we can cover it now, but I think it'd probably be better at the end, is to go over the tool that I will be grading. I can do a separate PowerPoint on that, or we can go over that, but okay. Okay, so let's go ahead and get going on this then. So some of the key terms that they start out with talking about is the epithelium, which is one of the 4 basic types of tissue, along with connective tissue, muscle tissue, and nervous tissue. Granulation, who can tell me what granulation is? I got people to talk to, so I'm going to have you guys get involved.
Is that the process when there's a wound and then that granulation starts, like those cells, in order to the healing process, right?
Yes.
To regenerate.
Yes, good. Yes. It's just what you said. It's the starting of the healing process, the tiny blood vessels that form on the surface of the wound to start the healing process. What about turgor? So turgor is, when you think about it, we do an assessment of skin turgor, right? What is that? What are we testing?
Rigidity of the cells.
Okay, what does that mean?
It's like due to the absorption and the fluid, skin then either becomes, when you, like if, for example, you pinch it and it doesn't go back.
Then what does that mean?
Dehydration.
Dehydration. The cells are, when you have good skin turgor, basically the cell contents, there's fluid in the cell that's pushing up against the walls of the cell. So it makes it, that's normal skin turgor, right? And then emollient, these are just kind of simple key terms. What is an emollient? So an emollient is basically like a moisturizer, something that's put on your skin to help soothe it or to soften it. And then what is debridement? Anyone? So debridement is the removal of unhealthy tissue from a wound. So what is tissue integrity then? The answer is actually on here. But tissue integrity is a state of structurally intact and physiologically functioning epithelial tissues, such as including the skin and subcutaneous tissue and mucous membranes. Why is tissue integrity important?
It's our first defense to infection.
Good. Good, yes. So the scope, you know how we talk about the scope of a concept. And here, basically it goes from having intact skin and an intact barrier to the outside to a disrupted skin integrity. And then there's that in between. So the integument is made up of 2 layers, commonly known as, to us, as the skin. It's epidermis and dermis, and it has the subcutaneous tissue underneath. And in this slide here, this is, A is a thicker skin, and it's basically like on the palms of your hands or on the soles of your feet. And then the one that says thin skin is more on other areas of the body. So I did put the learning objectives in for the week. And I always keep reminding you that by answering these learning objectives, you're going to be able to answer your quiz questions and your exam questions. So this is, and this is probably hard to look at just to be watching it on a small computer, but this is a concept analysis diagram that I actually found online. I did not create this. And it takes you from, so you have in the middle the tissue integrity, and then it goes into what is the attributes of tissue integrity. And then it goes to the nursing care, what things, how do you say it? What things influence it? So the antecedents is what precedes the concept for it to exist. So what happens in order for tissue integrity to exist? And that's going to be good nutrition, lack of external trauma, adequate perfusion, limited pressure on the site, it's affected by life cycles. So in other words, tissue integrity changes over the lifespan of somebody. Does that make sense?
Yes.
Okay. Lynn is going to answer me. Okay, so some categories of impaired skin integrity, trauma or injury, loss of perfusion, immunological reaction, infections and infestations, thermal or radiation injury, and lesions. So what, well, we'll go on because I think I have it. Let's see here. So we talked about age-related, or we said across the lifespan. So what is it about infants and children, or let's start with infants, that makes their skin different What is it about their skin that's different than even young children or adolescents or elderly?
They would have, like, for infants, they have less muscles.
Is it less muscle or what else?
Don't infants have more fat? Do they have more fat?
They actually have thinner skin and are more permeable. They have a more permeable skin and have less subcute fat, and that leads to a greater chance of fluid loss.
Okay.
We're talking infants, like babies.
Okay.
Okay, so what happens as somebody gets older? What happens in young children versus adolescents? So in young children, remember when you think about this, before they have puberty, they don't really have those sweat glands under the arms or the hair follicles in the pubic area. So they basically, that's kind of the difference in their skin. And then as adolescents get, as they enter into adolescence, those sebaceous gland activity, sweat glands, that all increases and their skin becomes more oily. And what is one of the big things that happens in puberty related to skin?
Acne?
Acne, yep. And then in older adults, their skin changes are that their decrease in elasticity, their supportive structures underneath, the lean muscle tissue, is decreasing. So that's how their skin is changing. So I'm not going to go hugely into this, but basically the physiological processes of the skin are to the protection, absorption, secretion, and excretion. I did put up in your, and I think I added one to this PowerPoint, but I put up 2 YouTubes that talk about a little bit about anatomy, physiology in the module, and also, what was the other one? There's one on wound healing, and there's one on pressure wounds in the module. Did anyone see those yet? Okay. I'm so excited to have you guys here. You guys, you got to talk. Because otherwise I'll just kind of go on through. So there's 6 major categories of impaired skin integrity. And those are the trauma, which can be intentional or unintentional, damage, intentional or unintentional damage to the tissue. So we're talking about from a small scrape to a deep wound that penetrates skin and subcu layers and maybe even muscle, right? Loss of perfusion, we talked about that, right? With the clot in his leg. Tissue requires oxygen in order for it to stay healthy. It can take small hits on without it becoming compromised, but a prolonged time of not getting infusion can cause the tissue to necrose. What is immunologic reaction? What do you think that is?
When the cells or white blood cells. Oh, I don't know. Sorry.
Well, you're kind of in the right direction. Basically, what is it? How do you say it? It's an allergic response. So it's an allergic reaction. So that's when you, somebody might get hives. What else? Even just not even as bad as hives, but maybe just something rough on your skin causes you to get red from it. But usually it's a response to a foreign substance. What about the infections and infestations? It actually has it here. What would that look like? Does anyone have examples of that? What would be an example of a bacterial infection? So bacterial infections can be like cellulitis, impetigo, fungal infections are things like, which one was it? It's the tinea, let's see, I know that wasn't, sorry, let's see.
Ms. Dorba, I have a question.
Yeah,
Would MRSA be an infection as well?
would what?
Would MRSA be an infection? Would
Yeah.
this fall? Okay.
Sure, what is MRSA?
I mean, it's a type of, I mean, it's an infection on your skin. It kind of eats your skin and it's kind of contagious and
So what does it stand for?
I don't remember, honestly. Let me look for it.
Anyone know?
It's methicillin resistant.
Methicillin
Resistant something.
Staphylococcus.
Oh, okay.
Yeah. Good. No, that is definitely. Okay. So these are some examples of infections and infestations. And every time I start talking skin stuff, it makes me itch. So let's see. So you have the herpes simplex, herpes zoster. What are these?
Those are systemic infections.
And those are viral, right?
Viral, yes.
Yeah. And what is, the one thing I was looking at was, and then you have the ringworm, that's here. And then what is the, what is this one? The Pityriasis rosea, I can't even say it, I'm sorry. So basically this one here is it's a common skin condition that it's scaly the way it looks, but they really don't, it really is kind of an unknown what actually causes it. So now we're going to go into the physiologic process of wound healing. I know we talked about this last semester, didn't we? Anybody remember talking about this? Primary intention, secondary intention, and tertiary intention?
Yes.
Okay. So do you want to? Okay, I'm going to go ahead and let me go ahead and I'm hoping this is going to work for you. This is very short. Let me see.
When school isn't a place you have to be, why not go to school where remote learning can be as remote as you want? Like a Verbo.
So in this video, we're going to discuss the 3 intentions of wound healing.
You probably can't hear that, huh?
So the first one is healing by first intention. And before we begin, it's important to remember that wounds, like this concept does not mean that you heal by first intention, then second intention, and third intention. These are just all separate ways.
Can you hear that?
Healing a wound, and they can be mutually exclusive. So the first intention is when you simply bring together
Yes.
the edges of the wound and hold them together. So this can be held together with sutures, staples, steri strips, and other and the like. And it's basically when the wound is easily closed and the dead space is eliminated. So as you can see here is the stitch has gone across here, and the dead space, which is below the skin, has just closed up on itself with a simple approximation of wound edges. Healing by second intention is when there's a bigger loss of tissue. So it's not a clean cut as if it were as a razor. It could be a gouge, for example. And this is when the wound requires gradual filling of the dead space with connective tissue. So what you're going to see here is that the edges of the wound were not brought together. And instead, the wound was just left to fill from bottom to top with granulated tissue. And as you can see, this leaves a much wider scar than seen by first intention healing, healing by first intention. So healing by third intention is a little bit of a mix of between healing by first intention and healing by second intention. So it involves delayed primary closure. So you're not going to stitch up the wound right away. Instead, wounds are intentionally left open for several days for irrigation or removal of debris. So as this wound is healing from the bottom up, common nursing intervention is to irrigate the wound and debride the wound of any scabs and other infection or anything in order for the granulated tissue to work its way up. And once some of the dead space has been removed and the inflammation has died down, the wound can be then closed by first intention, which is with typically a stitch or a staple. And as you can see, that this is a combination of both first and second intention, because you let the wound fill up from the bottom as you would in second intention, but then you also stitch it later on as you would see in first intention.
I think we lost the, sorry.
Today I'm going to show you the 5 foods you must avoid eating if you have arthritis.
This is the fun thing about this. Let's see.
Right now. My name is Mark Roach, and I'm the Senior Arthritis Correspondent for healthandwellnesstools.com. And the information I'm about to share with you is based on findings from some of the top.
The joys of doing this all online. Okay, you just didn't see the video at all there, but we're not going to replay it, but it is on your PowerPoint, and I'll post this PowerPoint. But the pictures coincided, right? Deborah, I have a feeling nobody's here. So, okay. All right, so we'll just quickly go through this because I know we went through this last semester, but I know that this has to do with talking about wound healing and the whole concept of tissue integrity. So there's 3 phases of the wound healing. The inflammatory phase is 3 to 5 days. And I think this is where basically the macrophages are cleaning the wound out. And then the granulation phase is where the new blood vessels start laying down the new tissue. And then you have the maturation phase, which can last, it can take a few months before actually the collagen remodels in the scar forms, and then actually it'll eventually go away, hopefully, if it's not too large of a scar. Consequences of impaired tissue integrity. Remember, we go back to, so I think about with thermal regulation, what comes to mind with thermal regulation? So,
The heat.
Say that again.
Heat.
Heat, okay. So Virginia, along that lines, what are you thinking with a patient who has the basically that their body functions are getting affected because their tissue it has been compromised, their skin has been compromised? What type of I guess I'm thinking about like thermal regulation, fluid and electrolyte balance, those kind of things. I'm thinking a burn patient, right?
Right.
What else?
It, like, to me, when I think about that, it's either too hot or too cold, right? So it's like how they're, whatever the problem is, how it's regulating, and if they're feeling, if their internal temperature is cold or hot, right? Something like that.
So their internal temperature is being affected because of impaired tissue integrity? Okay.
Yes.
All right. Anyone else? Okay. So we went over the risk factors. Part of those is the age-related risk factors. And we talked about that in infants, their skin is thinner. I always think of with infants, you know, my background is with the babies, and the really small premature babies have the really thin skin. And they actually lose fluid out through their skin. So you have to keep them in a humidified environment so that they don't lose their heat and their fluid. And then we talked about in older adults, kind of almost the same thing in a way. I mean, their skin gets thinner, and they can get dehydrated through their skin easier. They're more prone to the pressure wounds. Why are they more prone to the pressure wounds?
Older adults?
Yeah.
Because their skin is more fragile.
And what else?
And they don't have so much their skin is not so elasticity as it was before they were younger.
Yeah, and they don't have the muscle tissue there basically, right? And so a lot of times it can be just their bone mixed to their skin pretty much.
Yes.
Right?
Yes.
Okay, so other risk factors are health conditions associated with poor perfusion, malnutrition, dehydration, and the exposure to irritants. I'm trying to think of some examples. What kind of nursing interventions would be beneficial for any of these health conditions affecting tissue integrity? That's a lot, huh? So what kind of nursing interventions, let's take the first one, for impaired mobility? What are some nursing interventions that you could do?
Range of motion.
Okay.
Exercise. Change position.
Change position. Okay, good. How about someone who's, well, poor peripheral perfusion? So what did, like Dave had obviously he had perfusion problem to his leg. So what were some of the things he said he did, but a nurse could do too, to help improve the perfusion?
Like putting on compression stockings, sequentials, things like that.
Okay, good. What about the tissue trauma? What nursing interventions would help with someone more prone to tissue trauma? Kind of falls along the same as impaired mobility a little bit, but what other things? How does someone get friction, shearing? How do they get that?
By rubbing like on the, if they, like for example, if he doesn't use a pillow, you know, and he's just rubbing on it, it causes that shearing.
Okay. I kind of think I think of the shearing, especially is when, and we can prevent that as nurses, is when you go to pull someone up in bed, for example, somebody that's immobile, that can't really turn from side to side, you cannot take them like just from their arms and move them up in bed, right? You have to take them from the draw sheet and move them up gently, right? Have you guys been doing that already in clinical at all?
Yeah, that's what I was kind of remembering, but I didn't know how to word it.
Okay, okay. So let's see. Okay, so when we're going to do a health assessment on someone, what are some, let's say you have someone come in and, or you're checking someone that maybe has a pressure wound. And maybe the patient came in, I'm trying to think of a good example. Maybe they've come in from home and they're being admitted to the rehab facility or long-term care facility. What are some questions and what kind of assessment are you going to do on them? So I'm going to just keep talking because I don't know how many people are going to be able to answer. So basically with the health history, you're going to want to know the past and current conditions with the patient, any kind of family history. In the case where we're talking about the person at home and coming into the long-term facility, maybe, I don't know, I guess I'm thinking who's taking care of them, how many times a day is somebody there to help turn them. They talk about allergies, any medications that they're on, because there are quite a few medications that actually do affect the skin in some ways, right? There's some of these blood pressure medicines that actually make a person's skin thinner. In any history of any skin disorders that they may have, let's see, trying to think of, I'm trying to think of some off the top of my head, but any problem-based history, so changes in skin condition and color. So for, I'm kind of going back and forth between patients, but if someone like, I don't know, if somebody like Dave, my brother-in-law came in and you were doing a history on him. So his changes in skin condition and color, his calves were different color when he had the wound going on. Any new rashes or lesions, does the person have excessive bruising, loss of hair, changes in condition in their nails, and wounds slow to heal. So you're going to inspect for general color and condition of the skin, and again, checking for lesions, and you're going to measure them. Most likely you would even take pictures of them. You're going to figure out the characteristic of them, the color, the pattern. Are they raised, flat, dry, versus is there some sort of exudate coming out of them? You're gonna palpate, you're gonna feel the skin for the characteristic of it. You're gonna look at temperature, texture, and you're gonna check for skin turgor. Okay, and then you're gonna check for any kind of wound ulcers or wound pressure wounds. Some diagnostic tests. You have the Woods lamp testing. This here, I filled this out for you guys. So you have the Woods lamp testing, the tissue biopsy, wound culture, patch testing, which is done for people who possibly have some allergies and they're trying to rule out what they're allergic to. Serum protein levels, that's going to help you figure out nutritional status in the person. And then a complete blood count, which helps you look at white blood cell count. Sorry, you can hear it's getting a little noisy here. Sorry, guys. So primary prevention always is going to be to take care of the skin to start with, right? So skin hygiene. If you're taking care of our clients in the long-term care facility, in the hospital, wherever you're at, just making sure that they're staying clean, just basic hygiene, that they're getting adequate nutrition. Somebody who has a wound, who is not eating or able to eat, they're not going to heal, right? You have to have nutrients going in you. Avoidance of excessive sun exposure. So basically, you know, like we all know, put on sunscreen before you go outside, and pretty much try to stay out of the sun. Burn safety precautions. I mean, I guess you're talking about the fireworks on 4th of July. I don't know. And then dermal ulcer prevention. That's what we do as nurses, the turning, the just making sure that we have perfusion to the skin, to their skin. Here is this is the ABCDE rule for malignant melanoma, for ruling it out. So this is something that you can teach a patient if they've come in. I'm thinking about, I guess they could have come in for, to a clinic office, or you just have a client that has an unusual looking skin lesion. I don't know if you really would call it lesion, but, and this is how you tell the difference between what is benign and what is a melanoma. Okay. Some collaborative interventions. So what we can think of is, you know, medications, pharmacotherapy, antibiotics, steroids, chemotherapy agents, wound care, when we are cleansing a wound. What do you think we would cleanse a surgical wound with? Virginia, did you want to say something? So what you'll see.
The saline solution?
Pardon me?
Saline solution?
Yeah, typically it's a saline solution. I mean, unless the doctor has said something different, but typically it's just sterile saline that you're going to be cleansing a wound with. And let's see. So for nutrition, a healthy diet, we talk about increasing omega-3 fatty acids, vitamin C, vitamin A. So when you think about these things, be able to think about what exact foods you're going to tell that client or that patient that that you want them to eat, right? Okay. So interrelated concepts. Talked about a lot of these, right? I mean, just thinking about what, we heard today, even just with Dave, you know, he talked about the nutrition, the perfusion, infection, pain. Okay, so just anyone have any questions on this part? No?
No.
Okay. All right. So I think I'm going to go ahead and there is the rest of the PowerPoint just has a case study on there. And I'm wondering if we should, but it has a case study. It's from in your book. And here.
Is it the last page? Okay.
Yeah, yeah. And so basically, do you want me to read it, or do you guys want to, are you?
We could read it.
Okay.
Unless you want to read it. It's fine.
Okay. So Mrs. Ramona Garcia is a 76-year-old female. She's been admitted to the medical respiratory unit with pneumonia. After 4 days of having difficulty breathing, a fever, and a productive cough with purulent sputum, she reports that she has been sitting upright in the chair because she was having trouble breathing and she couldn't lie down. So when Mrs. Garcia's breathing was comfortable enough for her to be turned briefly, they did a full skin assessment on her, and that the nurses notes a 4-centimeter reddened area on the buttocks over the left ischial tuberosity that does not blanch to pressure. When we say does not blanch to pressure, why? Why do you think that is? Is this the start of a pressure wound?
Yes.
Okay. So recognizing that the reddened area is a stage 1 dermal ulcer, likely related to just the prolonged pressure, right, of sitting. The nurse collaborates with the patient, the family, and the other health team members and plans to have prevention, oh my gosh, on a plan for prevention of further tissue breakdown. So that includes frequent movement, positioning, adequate nutrition, hygiene to keep the skin free of moisture, and because urine and sweat can cause the skin to macerate, and in use of other relieving devices, pressure relieving devices. There's all of these really cool beds now that help with this. So Mrs. Garcia has a serious medical problem that has kept her in a sitting position, struggling for airflow for several days. And so continuously sitting up to improve her air exchange has also prevented her from relieving the pressure on her buttocks or her ischium, which she would have normally have noticed that and been uncomfortable and been able to move around. So poor perfusion from the near constant pressure on her ischium and a low capillary O2 level from her respiratory illness have begun to cause damage to her tissue. Because remember, we said you had to have good oxygenation to the tissues, right? So Mrs. Garcia's nurse identifies a reddened area of the skin that does not blanch to touch, and then they come up, basically they talk about coming up with interventions that would help her maintain, be in a comfortable position to maintain her, so she doesn't, to improve her air exchange, but also to protect her skin and to protect her from getting pressure wounds. Just offhand, what kind of nursing interventions are you thinking?
For the pressure wounds, Ms. Moore?
Yeah, what kind of positions could she be put in, or what are some of the nursing interventions you could do to help this patient out?
With the turning, every 2 hours, turning her so she's not in the same place.
Okay. What if she tells you, well, I can't breathe in a certain position? What are some other ideas?
What about, sorry, go ahead, Virginia.
Giving her oxygen.
Okay, that would require an order.
Because if she's sitting up, and she's tired of sitting up, maybe, getting an order for her to have a oxygen tank at home to help her breathe better.
Possibly. What about a different kind of bed or an egg crate mattress or
Like a pressure mattress?
Yeah, what about that kind of stuff?
That would decrease maybe the risk for her developing future ulcers or any pressure ulcers.
Okay, and then what about, we talked about nutrition. What about the nutrition part? Making sure she's getting nutrition, right?
Maybe like fruits, vegetables.
Fruits, vegetables, protein, fluids. Okay. All right. So, and so what assessment findings would indicate that her dermal ulcer progressed from a stage 1 to stage 2? So basically they're asking what would make it a stage 2?
There's a break in the skin.
Just 1 second. Meg. I apologize. My husband left the door open and we have a dog that runs. So the stage, going from a stage 1 to a stage 2, the presence of a shallow open ulcer with a red-pink wound bed would move it to a stage 2. Okay. All right. I think we moved through that. Okay. All right, guys. I think that's going to wrap it up for this section. I felt like it went a little roughly there.
Can I bring up something?
Yes.
Okay. So I've been trying to be kind of quiet. You know, it is 7:30 at night, so I appreciate that. But I want to throw something out to the group. You've got, I can't remember the person's name, the woman's name in the case study. What was her name?
Garcia, Mrs. Garcia.
Can you show her photo?
Yeah.
All right. So you have this woman, Mrs. Garcia, and she has this pressure ulcer, and it almost doesn't matter which stage it's in. It just needs some nursing care. So you have a couple of choices what you could do for her to help her. And one of them is to look at why this has all happened, of course, because you're going to do, you're going to do the nursing process. But given 2 choices, what do you think is probably the most important? Making sure that she has a great dressing change and you're doing it and cleaning her wounds and doing what's needed? Or do you think you might do better if you make sure that she's eating properly and getting a particular amount of calories based on her size, her weight, and whatever? I mean, what is the relationship between nutrition and wound dressings, and what are you going to do first?
I think make sure that her wound dressing is changed, that we're able to change her wound dressing, making it clean and without like making it worse by having like any kind of like making it worse to get an infection and stuff like that.
Yeah, that'll definitely prevent it from getting worse. But anybody have any other thoughts about the connection or what you really should be focused on at this point?
I agree with what Virginia said, just preventing from getting more infection or the wound becoming bigger.
Okay. So why do you think I'm bringing up this whole thing about nutrition and whatever? If she has the wound that she has, why am I asking you to make that connection? Or maybe it's not even important.
Because nutrition also helps, even whatever stage the wound is, it helps to regenerate, to heal. Even if it's a more greater stage, even if it takes months, nutrition it goes hand with the good care. If she wants to heal, and I would tell her, can you please call me, or I have here your schedule that your lunch is going to be at this time. I want to be next to your bed, and I want to make sure that you get a little bit of all your tray. Maybe motivating her in that way too.
Adriana, is there a particular food that you want to to emphasize or make or actually have her eat first or something like that? Is there a particular kind?
Protein and vitamin C.
Okay, Virginia, what is it about protein that you think would help?
The nutrients that it has, it helps her get those nutrients needed to heal the wound faster.
What's the connection between protein and swelling?
Oh,
Does anybody know? Okay, so can a wound that is swollen heal?
I would say
Kenny?
no.
And why, Vivi? Why would you say no?
Because I mean, if we don't have enough protein, we have deficiency, right? So there's no cure. We need to have enough protein. We have to have enough vitamins in order for our skin and our wounds to heal. And also, I think hydration is very important as well. The patient needs to be well hydrated in order to have a healing process and a faster healing process, I would say.
So you're right. A wound can't heal if the cells are so swollen. And think about it: if the cells are so swollen, they can't heal. They're already too full to heal. And as a matter of fact, sometimes you'll have weeping wounds when the cells break open. Right? Have you all seen that? You know, where you have just leaking from the cell wall. Anybody seen that in clinical?
Like, you mean like drainage from the...
Yeah. Right. So there are a couple of reasons that you have drainage. One is it's a natural process. It's the body's way of cleaning the wound. You know, it's really wonderful because that inflammation brings the cells to that wound site. But if it's too swollen, it won't heal. That's why, has anybody ever seen compression dressings? Kind of like what Dave was talking about, you know, when his legs had to be wrapped. You know, he didn't like it, you know, and he said, you know, it was really hard for him to wear them. But why do you think it would have been important for him to wear them? You know, what's the purpose of making somebody go through so much, you know, discomfort? I mean, what would be the purpose of you saying to him, well, you need to keep it on?
For a faster healing?
Yeah, because what did the compression?
The blood flow.
Yeah.
Yeah, because it compresses, correct? Yeah. So it allows the cells to not to be so swollen, you know, so it holds down the cells so that they're not stressed. And it's like a balloon that, you know, each cell is like a balloon. If the balloon gets overinflated, it will burst. Mm-hmm. And the same thing with cells. So bringing it back around to protein, what does protein do with a wound? What's the connection and why is it so important to kind of pay attention to the amount of protein people eat?
It helps in repairing the whole healing from the skin, from the layers, the muscles.
And it carries the oxygen through your body.
So you're now starting, you know, now you're back in clinical. And which blood value would you know, you're a nurse and you're looking at Mrs. Garcia and you don't know her very well. So which blood value are you going to pay attention to sort of get an idea about how much protein she's been taking? Because if she's not getting enough protein, her wound isn't going to heal. And so it's just not going to happen. You can do the best dressings possible. You can have the best aseptic technique. You can go in and clean those wounds and do everything the right way, and they're not going to heal. And you probably have seen that in clinical, especially with the elderly. So unless you have protein, unless she takes protein and has enough protein, Mrs. Garcia is never going to get better. You might as well not do anything at all. You might as well save the money. Don't do any wound care, but feed her. So Vivi, do you know what lab value you will look at first, or what would be important?
A protein test?
Yeah. Would that
Yeah,
be
but
it?
which
A total?
The albumin.
Yes, 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 yes. So that's how you're going to know. And that's part of the evaluation, because you're going to go in and you're going to say, Mrs. Garcia, unless you eat protein and you have enough calories, your body can't heal, because you need to get the protein and the calories into the cells so that they have integrity, they have turgor, and then your body will begin to heal. But the only way to know, because Mrs. Garcia will say, "Oh dear, I eat everything. I'm fine," and but the only way you're really going to know if she's actually getting what she needs is by evaluating or assessing. And the blood value that you're going to assess is, say it again.
Albumin.
Yes. Okay. So then you're going to look at the albumin and you're going to say, is it high, low? And you'll get, you'll get the trends, so you'll know. And then you'll be able to go back and say, I know, Mrs. Garcia, that you feel that you're getting enough protein. But what I would like to do is talk to you about how you can eat more, because your values are lower than you need to get well. So do you see how the concepts are related?
Yes.
So why do you think it took Dave so long to heal? Pull it back to your real case study. What happened? What happened with him?
I wasn't really there like the whole time, but it's like it's a process, to get to do the nutrition and get the labs and make sure that you're on time to cure, to start the process to curing it, right?
Yeah, and look at what happened with him. He was on the medication, he was on the warfarin, and of course you can't have green leafy vegetables and a lot of the things. He gave you so much information when he was talking about what he couldn't eat, because it interferes with the vitamin K and the warfarin, and your levels go up and down, your clotting values go up and down based on your diet. So he couldn't eat what he needed to eat. So is it a mystery that it took him longer to heal? No, not at all. You would expect it, correct?
Yes.
And the fact that his leg, Mrs. Thorpe, his leg is much bigger. One is much bigger than the other.
Yes. Yeah. I tried to get him to let me have a picture, but that was like his line was drawn right there. But yeah, in fact, I ask him continuously, why don't you have your, I mean, it'll be like this big compared to, a normal guy's calf. Yeah.
Yeah, it's not going to heal.
No.
For him, it's just it's healed now, correct?
Yes, yeah, it took a while. And for him, and it's interesting to think about all the concepts that go in together. I mean, he mentioned, he's very frank about having ADHD. He, during the time he had that wound, there was a lot of stuff going on. So he was under stress. He was, probably not eating very well at all. So there was a lot of things that were going on that for sure caused him to end up in the hospital to get it to heal. Yeah.
So ladies, it's very predictable. I swear we should do a course, not even a class, on inflammation. because you, Mrs. Thorpe, you had a great slide before on inflammation. But you know, ladies, when you know, healing is not a mystery. It's very predictable. It's like you can, if you understand inflammation, so much of what you are going to do in nursing will just fall into place. You'll see a wound and you will either be very, you'll be concerned because it doesn't fall in your expected timeline because you know the process. The body is very predictable in the way it heals. And so when you walk into a room and you say, gee, this wound is 2 days old, it should be swollen, it should be red, it should feel a little bit hot, then you're not going to worry about it. You're going to say, oh, it looks great, you're doing fine, because it's day 2.
Right.
You see that, and day 7 or day 5, then you begin to say, oh, then things aren't going well. Even though it may look better on the surface, it's not healing. And there's more inflammation and it's getting worse. So you know, it's really predictable. So is cancer. Cancer, I don't know, when do you do cancer and all of that? Do you do that did you do that in first in 119?
Oh, because I wasn't there for all their, did you cover cancer?
No, we didn't.
No, we haven't.
Okay, have you all taken care of or know people with cancer?
I have.
Okay,
I have.
yes. Vivi, how about you?
No, I haven't.
Cancer is only scary when you don't know what's happening. And cancer, just like any cell, because cancer is a cell, it's very predictable. So if you really want to relax with being a nurse and knowing when to worry and when not to worry, you've got to kind of know this slide, this wound healing slide, because it talks about inflammation. And so, and cancer is the same way. It's very cyclic. You can tell when somebody's going to get worse. You can tell when somebody's going to get better, almost, if you pay attention to the very basic nuances of cancer. So it, and I'm simplifying it dramatically, but if you pay attention, it's there. When people who have cancer, those of you who know people with cancer, they their cells start to swell because they're stressed, and then they leak. And the same thing happens with wounds. When the cells get too big, just like a balloon, they will leak. And then you have drippy wounds or very red wounds. And with cancer, it leaks into the lungs because that's the only place where it can go. And so many times people with cancer have a difficult time breathing, or they have fluid in their lungs and they have to have it drained because there's no place for all that leaking fluid to go. And so when people get what they think is pneumonia or something with cancer, you don't worry about it as much because that's the expectation of inflammation. Does that make any sense?
Yes, a lot.
Yes.
Yeah, so start to really begin to look at people and say, what the heck is happening with you? And then go back to the basics, you know, and say, what do I know about inflammation? What do I know about the body and how it will respond? And you won't have to guess anymore. You'll be able to predict. And inflammation is probably the most important thing that I think. I don't know about you, Mrs. Thorpe, but I think it's probably one of the most important things. And it's kind of one of those things that we kind of gloss over in some ways, you know, because it's not as sexy, it's not as exciting, but it certainly is the key to life. Anybody have allergies?
No.
No. Virginia?
No.
No. No allergies?
They're lucky.
Yeah, really.
I
I have
I have allergies to red meat and pork, that type of allergy.
Oh,
But not the seasonal type of allergy. Yeah.
so what happens to you, Virginia, when you eat meat or pork or whatever?
I was fine with that, but it was really weird because there was some time that I was living at my mom's, and I would do, I would clean the house, and I would start like just runny nose and watery, like just watery coming out of my nose. But and it would be all the time that I would be at my mom's house cleaning or doing stuff like that. But if I'm somewhere else, I'm fine. So that was kind of weird. I thought I was allergic to my mom's house, period, you know. But it just over time I started getting better at uh with that kind, and I never could find out what kind of allergy it was.
Huh.
Well, does it matter?
Well, I mean, now no, but it was just like it was kind of frustrating to be cleaning and just my nose watery, like
Yeah.
just it was
Well,
annoying.
and so you were experiencing an inflammatory response. And so your eosinophils are running in there. And so of course your nose is going to bleed, your nose is going to run or whatever. And so, and they only last a certain length of time before the other cells come in. So you could almost predict the length of time you would have a runny nose because of an allergy like that. And so it's really kind of fun when you kind of put those pieces together, because then you think, oh yeah, I've got this. And feel really smart, but it's really just understanding a couple of key factors. Good. No, it's late.
All right. So I will post this Zoom, but I will set up another time because I know Adriana had lots of questions, and there were a few people who had questions on the portfolio tools. Specifically, I'm going to discuss the one I'll grade. So okay. So I'll set up a time and we can do that.
Thank you.
All right.
Okay.
Okay. Thank you.
Yeah.
Thank you.
Have a good night. Thank you.
Have a good night.
Good night.
Thank you. Good night.